All right. So let's see here. So these are the specific objectives for the GU part. Okay, so you have a set of objectives for the GI elimination part, and you have this set for the GU. And you can see that it includes, so when you're studying, it's going to be the acute glomerular nephritis, nephrotic syndrome, and then congenital defects of the urinary tract. So that's going to focus more on the child in that part, right? And then go on down and look at what are some of the so just make sure these are the things for the GU that we're gonna some of them are covered in this slideshow. Some of them may be on I posted that other PowerPoint that's more from Iggy. And you can use that. I don't know. Some people like to use the PowerPoints as a way to keep notes, but you may not even want to open it. But so a review of the GU system. Remember the structure of basically the kidney is bean shaped. They're located one on each side of the spinal column. The ureters extend down from the kidney into the bladder. And the nephron is the kidney's functional unit. We kind of went through that a little bit last week. And it helps maintain the fluid and electrolyte balance. For a child, basically, it's a little different because right at first with a baby, you have some immaturity of some of the organs, and they could have been born with a congenital defect. So there's different things that can happen, but basically the anatomy part is the same. And this is just remember the nephron and what it does. We kind of review that overall. So the GU system, the differences in a child is that basically the kidneys operate at whatever. So if it's a very small child, the kidneys obviously are small, and they function at the size for the body size, basically. They do near adult function. It says 6 to 12 months of age. So those of you now that that are now switched to the OB area, you think about the babies and how their kidneys and their liver, everything's immature still. Infants cannot concentrate urine as efficiently as older children or adults. So therefore, what does that put them at risk for?
Dehydration?
Dehydration, yep. And they have shorter urethras that predispose kids to UTIs. Which sex for children does this pertain to especially?
Female.
The little girls, they love those little bubble baths, but that can predispose them to UTIs. Most kids achieve complete bladder control at 4 to 5 years of age. Sometimes that's a little longer for some kids, but usually by 5. I had a doctor tell me, well, a child doesn't go into college not still wet in the bed kind of thing. So that, I think you let parents know that. So healthy kidneys are the major controller of urinary elimination. They perform this function by filtering waste from the blood and selectively determining which substances remain in the body and which are eliminated. The kidneys basically maintain the homeostasis. They help contribute to the fluid and electrolyte balance and acid-base balance. We haven't gone a whole lot into acid. I haven't actually, gone into acid-base balance, but obviously that's extremely important too. Any problem that disrupts the kidney function has a potential to impair the homeostasis in all aspects of GU elimination. Interaction with other organs and systems is necessary for the kidney to function effectively. And when the kidneys are impaired, the buildup of toxins, obviously, toxins or toxic waste affect all other body systems and can have life-threatening outcomes. So this is just a little bit of review from that fluid and electrolyte week. Fluid volume excess. We're talking about the body has too much fluid, too much sodium, compromised regulation of our aldosterone and ADH, corticosteroids, extrinsic and intrinsic, other meds with effects similar to corticosteroids, which help that retain the sodium, also influence volume excess. And then remember, in pregnancy, fluid volume increases. I'm not going to go into too much pregnancy area. Really this week, the exemplars, I believe, are the glomerular nephritis, sorry, you guys, nephrotic syndrome, and what was the other one, guys? Congenital, right? Congenital deformities, okay? So one of the reasons why you can have fluid excess is a runaway IV. So maybe the doctor has ordered too much fluid, and you should have caught it, or nobody did, or and this is where our IV pumps are so important with pediatric patients. It used to be that the IV would get turned up too high, and then all of a sudden you go into the room and the client has 1,000 cc's in. That being said, typically in a pediatric unit, like for our babies, we never hung any bigger than a 500 ml bag. And you can see that that's kind of that end of the line safety measure, because it's a whole lot easier to take care of a child who just got, a bolus of, well, still it would be horrible, 500 mLs versus 1,000, right? So you can see where questioning IV orders and basically questioning the IV orders and double checking, okay, the doc has said PO plus IV fluids, but now the child is actually drinking a lot more. So now you really have to have a order that says PO plus IV equals 75 mLs an hour or 250 in 4 hours. Do you see how that changes? Does that make sense, guys?
Yes.
Okay. I'm okay with you guys talking. So another reason for fluid volume excess is increased intake of sodium in an IV. So the doc has ordered, or it's gotten hung this a sodium 0.9% of sodium chloride, and maybe this client got the whole bag or has had all of this hung, and now sodium is not being excreted, and now you've got this overload of sodium in the body, in the bloodstream. Or increase in intake of sodium-rich foods. Okay, so nutrition. Too much water and sodium. What happens to the sodium level and what causes the edema? So we're gonna kind of talk about this. So one of the things that happens is you have compromised regulation. All right. So you have an altered or inappropriate regulation of hormones, which balance sodium levels and water. So we're talking about the aldosterone and the ADH, or the anti-diuretic hormone. And we'll look at that a little deeper in a couple more slides, but that's what's going on. That's why this person has fluid volume excess. The manifestation as edema, and this can translate into a person with heart failure, chronic renal failure, nephrotic syndrome or other kidney diseases, cirrhosis of the liver, pituitary tumors, and adrenal tumors. So where does the edema occur? What fluid compartment do you think? Where does that edema sit? Is it sitting in the bloodstream?
The interstitial space, right?
Right, right. So, and this is just somebody, and we've all probably, you have seen people with more swelling than this, right? I mean, I've seen them where the whole, you can't even see the ankle. So, and this is just a slide showing you, this is 1+, 2+, 3+. And you guys saw that little, in skills lab, did you get to play with that one kind of foam looking thing where you can practice seeing what it looks like? Did you get to play with that at all?
No.
Okay. Look, when you're in skills lab, if you think about it, ask for that because it's kind of cool. Okay, so another part is the aldosterone secretion. So when you have decreased renal perfusion, you're going to have increase in renin secretion, and then you're going to come down here and all of these items start happening, right? You have the increase in plasma angiotensin 2, increase in potassium, a drop in sodium, an increase in ACTH, mostly because of this stress or physical trauma. And then it drops down to an increase in aldosterone secretion, which influences reabsorption of sodium and reabsorption of potassium. And then here is review the negative feedback loop for the antidiuretic or ADH. This so the posterior, so let's just start from the top. So the increase in sodium, which happened here, concentration in the plasma increases the osmolality of the blood, and then it stimulates the hypothalamus, which stimulates the posterior pituitary, which basically is just a storage house for the ADH, right? Which it stimulates posterior pituitary to go ahead and release the ADH, which then goes down to the kidneys, and the effect basically is reabsorption of water and increased plasma volume, decreased osmolality, and then it goes back up to the hypothalamus, and it'll stop when it doesn't sense this increase in sodium, right? And your results, though, will be scant urine because it's pulling the water back into the bloodstream. So another reason for fluid volume excess, the mechanisms of edema. So we're just this slide, I know it might seem a little confusing, some of the slides, and I tried to, so basically there's gonna be a few slides that now talk about the mechanisms of edema. All right. So some of those are the increased permeability of the blood vessels, which we just said the fluid moves to the interstitial spaces. The increase in the hydrostatic pressure inside the blood vessel, decreased plasma proteins are inside the vessels, allowing the leakage of the fluid to go out to the tissues, and blocked lymph system. So, and then hypokalemia, right? We talked, along with the increase of sodium, we increase the potassium. So with conditions that cause this increase in aldosterone, again, you're going to get the decrease in renal perfusion, an increase in renin, and then you're going to have this whole process happen, right? When intrinsic corticosteroids, which is cortisol, are secreted by the adrenal cortex, aldosterone secretion occurs at the same time, okay, which so that's causing the fluid volume excess. And then also another reason, and that's the excess corticosteroids, is if you have an adrenal tumor. Correction for this part is going to be, for this one, is going to be surgery. So when corticosteroids are taken, and we're talking the prednisone, the any of the medications that we've given or know about, or corticosteroid like meds, estrogen. What's the HRT again, guys? You remember?
Is that the hormone replacement therapy?
Yeah. And so this is all part of somebody retaining water. Okay. This is a child, just a picture of a child that you can see their face is a little puffy, most likely because they're taking corticosteroids. Edema can also, we just talked about a decrease in plasma proteins. So the loss of proteins through the kidney sorry guys, I'm not very good at these pronunciations, glomeruli, or nephrotic syndrome. And you guys did a nice job. We'll maybe look at your comparison charts a little later. Decreased production of proteins from a liver disease, or inadequate intake of proteins. Maybe the person is in severe starvation. So these are reasons why they would have a decrease in plasma proteins. Okay, so that was just a kind of quick review of what sets up a person to have edema, and a little bit on the fluid and electrolytes. So I'm going to, these are some anomalies of the GU tract that you'll see in babies. I mean, you'll see these when they're born, and it's one of your assessments, right, on a child. You pay attention. So you have cryptocortism, you have epispadias, and you have hypospadias. And I have a picture here. And you have chordae. So the chordae is a picture of this. And basically, the chordae is, there's a fibrous band, and it can be very tight, where the tip of the penis is basically bent all the way forward. Or it could be, mild, where it's hard to kind of tell. You can also have you can have I think it's an no, a hypospadias is what you'll get sometimes with a Corday. Obviously these, well, the Corday is kind of almost a little bit more of a simple surgery. They can just cut the fibrous band, and that should relieve some of that. The epispadias and the hypospadias can be a little different, but they can surgically repair those. Basically, what do you need to know? These are just some of the congenital I hate to use deformities. What do they say now? Not congenital.
Defects.
What is it?
Defects, congenital defects.
Defects. I like that word better. A congenital defect that can happen. Is it life-threatening? No. But is it psychological kind of thing for the parents? Maybe, so it could be one of those education thing that us as nurses are going to provide information for them. So we're going to get started into the nephrotic syndrome. And some of you have already done, I think 7 or 8 of you already turned in your comparison chart. So this is going to seem a little bit like a repeat of what you already did. Just so you know, this little guy does have nephrotic syndrome. He previously received his steroid therapy, and he's now receiving CellCept immunosuppressant therapy to control the process. During the acute phase of the nephrotic syndrome, the child may have massive edema because the blood proteins are lost in the urine. Their skin is pallor, so pale. And so this is in some of the reasons why. So you have, in a lot of you, we've already kind of almost touched on this. The increased glomerular permeability allows albumin to get excreted into the urine. The protein is excreted in urine and causing the decreased protein in the plasma. And decreased protein in the plasma causes the increase in edema. There are 3 different reasons why a child would have nephrotic syndrome. 85% of children get quote unquote the idiopathic nephrotic condition called MCNS. So normal or slightly minimally changed appearance of the glomeruli on microscopic evaluation. It occurs most frequently in children 2 to 5 years of age. And again, this is kind of one of those reasons we're going to look at the chart comparing the 2. The second part reason for nephrotic syndrome occurs after or is associated with any kind of glomerular damage from a known cause, or congenital nephrotic syndrome, which is an inherited disorder. Manifestation: edema, anorexia, fatigue, abdominal pain, increased weight, and respiratory infection. So you could have the child come into the office. Has anyone seen this in your clinical experiences? Have you seen a child yet with this?
No.
Not yet? So what happens in nephrotic syndrome? How about if somebody tells me what happens? Anyone want to take a stab at this? There's a couple of you that did a really nice job on your, the ones that turned them in, they looked nice. Tell me what happens with nephrotic syndrome. No one wants to take a stab?
It's a kidney disorder that's marked by protein in the urine, hypoalbuminemia, increased coagulation, edema, and hyperlipidemia. And the pathophysiology behind it is the glomerular, I can't say that word, protein permeability increases. And then so you have urinary excretion of protein, especially albumin, increases. And then the hypoalbuminemia develops and causes a decrease in the on-clonic pressure.
Good. Keep going. Good.
And then there's like leakage of fluid into the interstitial spaces that leads to the edema. Sorry, my husband's mowing the lawn now. Darn it. Hold on. So they get like fluid retention, anorexia, hypertension, and then a decrease in urine output.
Good. Very nice. So I really like the way, Shannon, that you described it, because you're not only describing the pathophysiology, but you're also describing what this child's going to look like when they come in, right? Let's see. Oops.
It also says they're going to have like the periorbital edema,
Yes.
and then they'll have hypertension, but also like orthostatic hypotension, ascites, and then in this circumstance, one of the differences between this and the glomerular nephritis, I can't say that word either, is that these patients will have like swollen genitalia and ascites, in addition to the edema.
Good. Good. Anything else, guys? Do you want to add anything?
So for these as well, like some of the treatments would be like, obviously you're going to restrict the sodium intake, provide frequent rest periods, and then diuretics would be used. And then just maintaining the fluid balance and the hemodynamic stability.
Good. Excellent. Anyone, so let me just add a little bit here. So in addition, the serum values of the cholesterol and triglycerides are elevated. So this change is thought to result from the increased stimulation of the lipoprotein production because of the decrease in the oncotic pressure. Loss of the immunoglobulins into the urine is common in the nephrotic syndrome. So levels of the immune globulin G are decreased, which makes the child more susceptible to infection. So something we have to be very careful of. Before the use of antibiotics, infection was a most frequent cause for these children to die. Children with nephrotic syndrome are in a hypercoagulable state. So very important, predisposing them to venous thrombosis. This tendency occurs as a result of several factors, including the decrease in intravascular volume, hypovolemia, which causes an increase in the concentration of the RBCs and platelets, right? So if you have someone that's dehydrated per se, so decreased fluid volume, then they may not have had their RBCs and H&H and hematocrit, that's all going to seem falsely increased because of that, making basically, I mean, I'm thinking about their blood being almost a little sluggish, right? Which sets them up for higher incidence of the venous thrombosis. The urinary loss of proteins that inhibit coagulation also contribute to the risk of the thrombus formation. So as Shannon pointed out, you already pointed out a lot of this. So protein in the urine, making the urine almost frothy looking. Microscopic hematuria, so you might not be able to see the blood cells, but there are some in there. Decrease in urine output, massive edema, which can develop over several weeks. Usually in the extremities, abdomen, and genitals, like Shannon had said. So again, a nursing thing would be making sure the parents are weighing the child, right? Initially, the periorbital edema on awaking that decreases during the day. The snug fit clothing and shoes because of their weight gain. Pulmonary edema, which you're going to hear the crackles, pallor, blood pressure is usually normal, and irritability, anorexia, vomiting. So again, a test question may have any number of a select all that apply for nephrotic syndrome, right? Also, these children could be misdiagnosed with allergies because of the periorbital edema and the respiratory symptoms, right? Abdominal pain because of excessive fluid in the abdominal cavity can lead to diarrhea and a decrease in absorption of nutrients for them. So compromised or altered regulation of aldosterone. The fluid is not able to stay in the blood vessels because the proteins do not hold the fluid in. This is kind of a repeat a little bit. Fluid leaves the blood vessels and flows out into the interstitial space. There is less fluid in the blood vessels. Receptors recognize this decrease and activate the renin-angiotensin-aldosterone process. Sodium and water retention takes place by the kidney in an effort to increase the fluid in the blood and to prevent the hypovolemic shock, which is probably a little bit why the blood pressure stays normal, right? With minimal change nephrotic syndrome, what else with these kids? So I already said the immune globulins are lost, resulting in decreased immunity. Liver manufactures additional proteins. So you're going to have the increase in cholesterol, increase in triglycerides, increase blood clotting tendency because of the increase in RBCs and a decrease in coagulation factors. Now we get into the acute post-streptococcal glomerular nephritis. So basically, I mean, nephritis alone tells you inflammation, right? So in acute glomerular nephritis, after a strep infection, is thought to occur as a result of the immunological response of the body. The body responds to the strep bacteria by forming antibodies and which combine with the bacteria antigens to form the immune complexes. These antigen antibody complexes travel through the circulation and they become trapped in the glomerulus and activate an inflammatory response in the kidney, in the glomerular basement membrane. This causes an inflammatory response, damage the glomerular capillaries, and reduce the size of the capillary lumen. The process can cause a decrease in the GFR, leading to renal insufficiency. And sodium and fluid are retained, and the child exhibits the edema and the oliguria. In addition, injury to the capillary walls interferes with the permeability. So the larger molecules and structures such as the red blood cells, casts, and proteins can pass through into the urine. So some commonalities there, right? So manifestations, hematuria, proteinuria, hypertension, edema, and renal insufficiency. This slide just kind of talks a little bit, the first couple ones of what I just said. It is more common in school-age children 5 to 12 years old. Why do you think? Why do you think this would be more common in kids 5 to 12? What happens?
While they're starting school, they're more exposed, I guess, to infection like strep infection.
Yep, that's what I think. And they haven't been exposed to this, typically to strep in the home, or maybe they're in a more of a closed circle of people they're around, and now they go into their kindergarten class in a typical day, a year, and they get exposed to these things. So the post streptococcal after certain strains of group A beta hemolytic strep infections. So you can have the skin, which is impetigo, you can have strep throat. It can develop 10 to 14 days after the strep throat. All of a sudden they will have hematuria, proteinuria, and oliguria. Or 3 to 6 weeks following the skin infection, which probably, that's quite a ways after. So sometimes for a parent, would be hard to even think about connecting the dots with the skin infection. 95% of the children will recover within a couple of weeks. It also can be associated with systemic lupus erythematosus, so SLE, lupus. These are just some pictures. That's of obviously strep throat. This is impetigo. In acute glomerular nephritis, the clinical manifestations are going to be the hematuria. So in this case, you are going to see it. So smoky or tea colored, right? And you can see here, this is how dark it is. That's tea colored. So when you're describing urine, and why do you think it's not red? I'm just asking, why do you think it wouldn't be red, bright red?
No blood.
Sitting for a while, exposed to oxygenation as well.
Yeah, I'm thinking it's probably because these are broken down red blood. The blood cells are kind of breaking down. And to me, red is acute, like something injured the kidney is why, or the bladder. And so that's why you would be getting red, right? So mild proteinuria is possible. Abrupt onset of edema, so eyelids and ankles, so the whole body basically. Hypertension due to fluid overload, and the damage of the glomeruli. Sorry, guys. Decreased urine output, abdominal or flank pain. You will have a fever, and pulmonary edema. So you can see some of these symptoms can be the same. When you look at what the lab results would be, you're going to do a UA. You're going to look at a CBC, do a throat culture, a skin culture, even though now we know, well, it's 3 to 6 weeks after the child had the skin breakout. You may not have something positive to have from that culture. And you can do immune studies. So a positive anti-streptolysin O titer indicates the presence of the antibodies against the strep. So that's going to tell you something. And low serum complement. I have no idea, honestly, what C3 is. Low serum complement. I don't know what that is. Does anyone read anything on that? So nursing diagnoses for a child or someone with acute glomerular nephritis and MCNS. You could have excess fluid volume, risk for impaired skin integrity. So imbalanced nutrition. Are all of these concept-based?
Yeah,
Is fatigue a concept, or is it activity
I think it's activity intolerance.
is that the concept? I honestly have to go back and look at the list a lot of times. But remember, when you're thinking the nursing diagnoses, to think about concept-based ones. All right. I believe like risk for impaired skin integrity, I think that is okay. And remember, with risk, you don't have evidence. So here's a list of collaborative interventions for these kids. Other immune suppressants used if prednisone doesn't work, and further workup. You might do a kidney biopsy. For the MCNS, 90% of the patients get complete remission with steroid treatment. Acute glomerular nephritis, there usually is a return to normal within 6 weeks with the supportive care. So again, you're looking at, with the MCNS, they're going to get their prednisone. They might get IV albumin, be on a diuretic. They have to have no salt or low salt, and antibiotics. With the acute glomerular nephritis, maybe some blood pressure meds, diuretics, the low salt diet, but they're not going to give any antibiotics unless there is a strep infection or some reason to have that. Some nursing interventions: measure the abdominal girth, test. So why this is when we talk about rationales. Why do you think one of your nursing interventions is to measure the abdominal girth?
Because of ascites?
Yeah, it's an assessment for ascites. So on your rationale for measuring abdominal girth is to track ascites, abdominal ascites, right? Test urine for protein, blood, dipstick. So each one of these, when you put it down, understand why you're doing it. So when I say to you, you need to put on your care plans your rationale, or I don't know, it's not in this class, but I have people writing test questions, and I think you guys do that in one of your classes. But the rationale is saying, why did you tell me to do that? That's what divides us as registered nurses from your CNA that you're having help you. You're giving her these, like, well, the measuring abdominal girth is a good example. You're telling her to do that, although that might be something you want to do, but you understand why you're having her do it. Okay. Any questions on this, guys? So like if I had a test question, and I'm not saying, I'm just trying to come up with test questions, and I had some of these listed and I had rationales off to the side for you to match the rationale to them, that would be reasonable to have, right? So here's a question. The nurse is assigned to care for a recently admitted 7-year-old child with acute glomerular nephritis. I am going to know how to say this by the end of this, huh? Which of the following findings indicates a need to call for the healthcare provider? Which one? Don't let it throw you. What do you think?
D.
Who said that? Was that
Brittany.
Brittany? I was going to say, yeah, D. Definitely. That's an acute finding. I guess that's the better way to say it. Of 2 pounds overnight of fluid. Okay, for a child, that's a lot. So here's a case study. So Dean is 3 years old and he's brought to the clinic by his mother. He has a history of a fever, sore throat, slight cough for approximately 8 days ago that lasted for 3 days. So let's see. So this was just a history, right? So if you were thinking about a background kind of SBAR, this would be part of that. That he had a history of a fever, that sore throat, slight cough, that lasted for about 3 days, about 8 days ago. Yesterday morning, he woke up, he had puffiness around his eyes. He got up and the swelling, he had some swelling in his lower legs and scrotal area. His appetite is decreased and his activity. So this morning, Dean's mother noticed that his urine was the darker in color, so that tea color, and less than usual. The physical exam now does not appear, he doesn't appear acutely ill, though irritable and fatigued and pale skin. So remember that kids like this can get misdiagnosed, right? His vital signs now, it looks like fairly okay, and his temperature is 98.4. But what there is I mean,
His
so
albumin.
what with the urine dipstick? That's not good, right?
Right.
The protein +4 for protein and having blood in it, and then the rest of the blood workup. Those are that is what's telling you really this and this his darker urine, right? It really, the vital signs aren't telling us anything. But us looking at him in his urine and the history of his urine and now his lab results help bring it together. So which condition is occurring?
Nephrotic syndrome.
Okay. No, what condition is?
Is it nephrotic syndrome? Because he's got the increased cholesterol and the decreased albumin,
Yes, good catch. Yes,
which is one of the differences between that and the glomerular nephritis.
good. Yes. Does everyone see that? So secondary to what? So his fluid excess related to really so he has nephrotic, so he has related to excess fluid volume, which is related to, what do you think?
A decrease in albumin.
So what do you guys think?
Hypoproteinemia.
That's part of it. So
It would be like fluid excess related to hypoproteinemia, secondary to the what was it? Dang it, I forgot the word for it now.
So, so fluid excess. So first of all, it's nephrotic syndrome. The fluid excess is fluid excess related to decreased excretion of sodium and retention of fluid. Right? Secondary to the MCNS. And then as evidence would be all of this stuff. Right? Sorry. I mean, the protein, would you say it was it would be hyperproteinuria, right? Or hypoproteinemia. That's not necessarily wrong, Hugo. But what they're saying is it's related to decreased excretion of sodium and the retention of fluid. Okay. So what are our goals for this child? What do you think? What's some of our nursing?
Sodium restriction, diuretics.
Okay.
Weights.
Weights, yeah. So the collaborative intervention would be the medication. What medications would they give?
Glucocorticoids, diuretics.
Okay. So far I'm only hearing Shannon and Hugo and Brittany. I know I have three more people in this, more than 3 people in this class. Okay. All right, so fluid volume excess, some general clinical manifestations, and we really kind of looked at this already, okay? Some of the things that might set out on this is if you're talking, what is anasarca? Up here, it says edema, some of the anasarca. What does that mean to you?
Generalized swelling.
Yeah, just generalized edema. The person is, so, and it can be, so in kids, well, let me put it this way. In adults, the edema you'll see sacral, scrotal, in the thigh areas, or if they're sitting kind of upright, it'll collect in the legs. And this can be as, well, it can be so bad that the skin starts breaking, right? And fluid starts seeping out. When I think anasarca, that's what I'm thinking. So causes of hyperkalemia. And I'm going to, let me just, sorry guys, let me just, so again, we had part of, you had the increased sodium and you have increased potassium. What are some causes in that could be happening? So you could have that, you've given too much potassium was ordered. The movement of potassium has moved from inside of the cells out to the plasma. or it could be we're causing it also by giving potassium sparing diuretics. Some other reasons, you could drawing blood from areas where the IV fluids with the potassium are running. So they typically, a good phlebotomist does not draw blood from an arm that has a running IV fluid, okay? They could have put the tourniquet on too tight, and now it breaks those red blood cells and you get a false potassium. Some nursing interventions to help potassium and sodium imbalances. So basically, don't administer potassium in the IV fluid unless the urinary output is adequate. You guys probably went through this first semester, right? This kind of review?
Yes.
Okay, monitor IV labels and rates carefully. Know how much potassium is in an IV and how much PO potassium is being ordered. We gave a lot of potassium PO to our patients first semester. And you did have to make sure that they didn't actually have any in the IV. Monitor their potassium and sodium levels, monitor levels of potassium in shifts. You know, you're looking at acid-base disturbances. Consider other reasons for a high potassium. Teaching about the foods, so nutrition-wise, foods that are high in potassium and low in sodium. When you're talking about the potassium sodium imbalances, again, this is review. Evaluate cardiac rhythm. Know which meds retain the potassium and sodium and which medications cause a reduction in these levels. Ensure safety. So again, looking at keeping the person safe from seizures, a change in level of consciousness, and that can be associated with dehydration and changes in the sodium, and evaluate bowel function that affected by the potassium levels. I want to make sure I go through stuff that is going to be. I'm going to let you guys review these slides. Let's see. Okay. So that slide could be important, right? It's on nursing interventions, just general across the board nursing interventions for fluid excess. Now, going into obstruction in the urinary system. Most common sites are the ureteropelvic junction, the ureterovesicular junction, posterior urethral valves, and also we talked about in the you know, the chordae, the epispadias, the hypospadias. So hydronephrosis, what is hydronephrosis?
Too much fluid in the kidneys.
Too
It's like
much.
caused by a backup of urine.
Yes. So what can happen, and I'm gonna just use from not a lot of times, we would have an infant born and we would know ahead of time that by ultrasound, it looked like one kidney, usually it was just one kidney, had some hydronephrosis going on. So that infant would be born, and us as nurses needed to make sure the doctor would reorder a renal ultrasound for the infant before they left, and the infant would be put on, what do you think they would put them on as kind of a prophylactic? So you've got this urine that's backing up into this kidney.
An antibiotic, right?
Yeah, yes. They'll go home on, usually it was like an ampicillin or something, and the parents would give it once a day, usually once a day. And then the instructions would be they would come usually they went up to Stanford or UCSF or something to figure out how they were going to fix this, if it hadn't resolved. But in the meanwhile, this was going to keep the infant from ultimately possibly getting septic, right? So this was extremely important that the parents understood this. I'm looking real quick at my chats. I just want to make sure. Nephrotic, thank you for pointing out. General edema. For the comparison chart assignment, it says giving examples in the rubric. Can you explain what you mean by that? That was from Kelly. Kelly, let's see, says giving examples in the rubric. Yeah, for the comparisons. I'll have to reread that. Kelly, do you have it up
Yeah, I can.
right now?
Just a sec. Okay, comparison chart, nephritis and nephrotic syndrome assignment. Description of criterion, complete chart comparing acute glomerular and nephrotic syndrome, giving examples for full marks. It also says in the overview of today's lesson regarding that assignment. Hang on, moving pages. It says during class, chart, compare and contrast nephritis and nephrotic syndrome with short child case study examples. So I'm assuming that just means answer the questions from the case study and use them as an example as how the nephrotic syndrome one would present, I guess.
Yeah.
It also says submit proof of completion of case studies as individual and or small group
Yeah.
assignments. So
I didn't. No, I didn't, guys. I didn't put. I technically don't have a case study this time.
Okay.
It's the. I couldn't find a good one.
Okay.
Yeah. So, just do the comparison chart.
Okay.
Yeah. I tried to find one. I found an adult one, but I don't know. We'll see what, I don't think we'll
ignore the
have.
with examples part.
Pardon me?
Should we ignore the with examples part?
I'm trying to remember what the other people put on their other
Any of you 9 people want to speak up?
Kenya. Yeah, Kenya did what did you and who else turned it in? Kenya, Claudia, what did you guys put there? Because I looked at
When I asked you about that during your office hours, you said just to do like the assessment and what is different between them and like the nursing care and what you would do for one versus the other.
yes, that sounds sorry. That sounds that sounds good.
Yeah,
I
that's
should have made
exactly
it
what I did
clearer
too
in
as
the
well.
rubric. Pardon me?
Oh, that's exactly what I did as well as Kenya.
Yeah. Yeah. Does that make sense, Kelly?
Yes, absolutely.
Okay.
And is this an individual assignment?
Yes.
Okay.
Yeah. I think I made it individual, guys, because I really think as long as you're not copying and pasting, it's going to help you for the exam, right? Because if those are 2 of the 3 exemplars for the this part, obviously there's going to be questions from those, right? So it's just going to help you study. Honestly, I would even consider doing a concept map on them, on each one, if that works better for you.
Miss Thorpe, that's the way I set up mine. I put like key things for me to remember, like kind of for like the quiz. And then I set up everything like if it was a concept down, going from top to bottom, like for the quiz. That's how and then compare, I highlighted 2 different colors to be like, what's the difference and what's the similarities.
Okay, good. Maybe at the end, once a couple of you can share those, okay? Let's just, I'm going to just, because you can read some of this is, so again, these slides that are here are talking about, and this is part of your objectives, right? The urinary obstruction of the urinary system. So these are all items that can have an effect on the urinary system, right? So on this VUR, this is vesicular I tell you, ureteral reflux, VUR. So this is a valve-like mechanism at the junction of the ureter and the bladder, okay? So here, okay? Which prevents urine, that should prevent urine from refluxing back up into the ureters. As the urine fills the bladder or as the bladder contracts during the voiding, the pressure in the bladder occludes the opening to the ureter. When a defect in this VUR results, basically it's not working right? So this is a congenital abnormality, and it can be associated with a lot of the infant having a lot of UTIs. And it can be seen in families. The VUR has 2 mechanisms that contribute to the UTI. The bacteria in the urine can be carried back up to the kidney, which we talked about, causing pyelonephritis and renal damage with scarring. And it also, when the urine refluxes into the ureter, it can return back. It goes up and then returns back to the bladder, which causes the bladder to basically have this residual urine all the time in it, which increases the risk of bacteria growing. So there's different grades, okay? And honestly, when you're in nursing, a lot of times, you'll see this in that ultrasound that they'll do with that infant after they've left the hospital. So you may not ever get to see this unless you're in pediatrics taking care of this baby now or this child that still is having this problem go on. So, and just know that grades 1 through 3, so follow-up cultures with no treatment or prophylactic antibiotics. So they will follow this child just to make sure that, that there's nothing, no bacteria, nothing going on here. So grade 1 through 3. Okay. Now, a first line of treatment, endoscopic injection of a bulking material protects the wall in the ureter to prevent the reflex. A second line of treatment, and this is only for 4 and 5, with recurrent UTIs, surgery for implantation of ureters into the bladder. So they basically fix the area. And this talks about UTIs. Basically, when we're talking about this, it is more focusing more on children, although you can see that it does talk about the difference in males and females here. Couple of things I just want to point out to you. When you're trying to diagnose a UTI from a urine specimen, obviously in babies, in little kids, this can be hard when you think about trying to get a sterile specimen from them. And what is, first of all, what's the difference between a UA and a UC? Specifically in the collection, probably from this.
The analysis versus culture?
Urinalysis versus what?
Culture?
Culture, yes. So what do you think as nurses we want to make sure happens or doesn't happen before we get that specimen for a urine culture?
I mean, it would need to be a clean catch,
Right?
Avoid
Yes.
antibiotics?
Say that again?
Avoid antibiotics?
Yes, who said that?
Marco.
Yes, Marco, yes. So at any point, if you know you're doing a culture, it could be a blood culture, like we would have babies come in that were sick. Doc would order a blood culture and lab work. Even though his next order is give ampicillin and gentamicin, we don't give that until that blood culture is drawn, okay? Otherwise, you screw up your specimen and we never know what might have been going on, or, we could be treating the wrong bacteria. So yes, I know, okay, so I don't know if anybody has seen these pediatric specimen collection bags, but let me tell you, in babies, this is not a fun prospect, and I'll show you why. Let's see here. I thought I had it. This really needs to be. So if you're going to have the parents do this, these are the different steps that you're going to have them. I put, because probably they have you, this is probably in reference to, for prevention of urinary tract infections. So giving the full medications for the number of days that it's supposed to be given. Just because the baby's starting to feel better, you still have to finish them. That's with anybody. Wiping from front to back, avoiding holding urine, avoid bubble baths. These are all those things that you would teach the parents. Now, right now, these slides probably should be switched. This is a bagged urine, and they make it look so simple. For a baby, obviously for a little boy, it's a little easier, but for a little girl, you can see that you can put this on them, and invariably they will, especially those first few days, a stool, and you'll get a mixture of meconium and urine. And what happens is, it used to be we would keep trying, we would clean it all off, reapply it, and pretty soon the baby's skin and they're getting raw from this bag going on and off. So that's why really, if you want this UC, you're gonna ask for a straight cath. It's just going to be more accurate, and it's going to be simpler for the baby in the long run, and cause less, really damage to the baby's skin. It's just easier, and safer, really, ultimately, for the baby. So some of the sequelae from UTIs, one is renal scarring, because the UTIs keep coming back. This is more frequently seen in infants less than a year. And it causes decreased arterial perfusion to the kidney. That's kind of a given, right? And it triggers the renin-angiotensin mechanism to release aldosterone, sodium retention, and fluid retention, and increases blood pressure. So this can keep going around and around, right? So review this slide, some of the causes of UTIs. Clinical manifestations. They can be vague and nonspecific. And collaborative care, let's see. We talked a little bit about that. Renal ultrasound, avoiding erythrocystogram. Let's see. These are for acute renal failure, indications for dialysis. Because we're not really going into, okay, so what best describes acute glomerular nephritis?
B.
B. Yes, occurs after a streptococcal infection. Any questions on that?
No.
Okay. A nurse is assessing a child who has nephrotic syndrome. Which of the following findings should the nurse expect?
A and C.
Just tell me what you are looking.
Anorexia is one of them.
Okay.
Hyperlipidemia,
Yep.
edema,
Urine.
protein in the urine.
In the urine. Right. What about polyuria?
I have to remember what that is.
That
Isn't
means
the-
a lot of urine, and I don't think that would be true, right? Because they would be actually withholding the urine, is it?
Correct. Yes.
Isn't the
Right?
proteinuria
Because
form?
because the urine, it's actually closer to oliguria, right? Because the urine, the fluid, remember, is getting pushed out into the interstitial spaces and not in the blood volume. So that's the whole, you're going to get decreased urine. All right. So yeah, all the four of those, it's anorexia, hyperlipidemia, edema in the ankles, and urine dipstick of 2+. Whoops. Yeah. Okay. I know I didn't give you guys a break. Let me. So I'm gonna have. Who wants to share? Just share their, because we're almost done, guys. A couple of you want to share the. Let's see. I'm sorry. What is required for the comparison chart? So a couple of you, would you like to share your comparison charts? I think that would help people. Who wants to share? Kenya or Claudia or Shannon or Hugo, or who else? Who else turned in already?
I haven't done mine yet. Otherwise, I would share. But
Okay. Who else was that I looked at? I just kind of breezed through them earlier.
I'm trying to find mine real quick, Ms. Thorpe. I don't mind sharing. I don't care.
Okay.
I just need to look for it in my stuff.
Okay.
do I remember somewhere that it was supposed to be an in-class, the in-class assignment or something like that too? Did I see that somewhere?
I think we said we would talk about it.
It does say in class on the overview for today.
Can you guys see that?
Yes,
Yeah.
we do.
Yeah. So Hugo, I mean, Marco, right? Yeah. Marco, go ahead and talk to us about it.
So pretty much, I just broke it down with like, as you guys can see with acute GN, it develops only from excess immune response within the kidney tissue. The primary cause would be infection, examples, and this was mostly like adult related information. I would add on like strep to as far as the infection, like TB, Heps. These are type of infections that potentially cause acute GN. The symptoms, according to Iggy, usually develop about 10 days after the infection. Another cause could be like multi-system diseases such as sickle cell. It's also known like drugs and inherited disorders can cause GN. If the client develops RPGN or chronic GN, it's usually it's going to end to end-stage kidney disease. Signs and symptoms, the main ones I would focus on would be like the edema, the proteinuria, the hematuria, the hypertension, obviously because of the edema or fluid overload. Changes in elimination pattern. We're inspecting for skin lesions, and that makes sense because of the edema.
And also because it could be part of the strep infection, right?
Correct.
Yeah.
And then like laboratory assessments, we're looking for, protein, red blood cells, and then obviously like the urine being dark or tea colored, right? We usually want to try to collect the specimen first thing in the morning because it's the most concentrated. And then I drop down like the total protein assay normal range to like abnormal range on what we'll see. It's different for kids, so we'll definitely look at that. We'll see an increase in creatinine and bun. So that's pretty much indicating that there's an impairment of elimination. We'll see the GFR decrease to about 50 mL per minute. If you want a precise diagnosis, we need a kidney biopsy. That's also going to tell you the prognosis. And then as far as management, really, primary for acute GN is to manage the infection, right? Via antibiotics or hygiene, kind of educate the patients on proper hygiene, including foods and stuff. We're, also going to modify, if we need to modify the immunity with corticosteroids such as prednisone. We're going to, prevent complications, in particular fluid and electrolyte imbalances, since we're retaining, urine. And then if we need it, dialysis would be another, something that we could do to help filter out that blood. With nephrotic syndrome, it's usually more of a immunologic kidney disorder, which, as we mentioned earlier, it increases glomerular permeability, which means larger molecules are going to pass through the membranes and be excreted. In comparison to acute GN, the most common cause is an altered immunity with inflammation, which leads to developing a massive loss of protein in the urine. In comparison to acute GN, it's greater than 3.5 grams per hour in a urine sample. In a 24-hour urine sample, we'll have some edema formation, decreased albumin levels, or hypoalbuminemia. It may cause, Iggy said it may cause altered liver function, but it sounds like we're going to stick to it. It does cause altered liver function.
Okay. Yeah. Because of the sorry. Excuse me. Hyperlipidemia. Yeah.
And if untreated, it may lead to ESKD. Signs and symptoms, like the big ones for me were like the proteinuria, the hyperlipidemia, and the edema. So now Iggy kind of focused a bit on the diet. So if GFR is normal, we're gonna continue to maintain adequate protein, if needed. If the GFR is decreased, then we should decrease protein intake, and then obviously restrict sodium. And by doing that, you're kind of helping out with, you should be helping with the edema and the hypertension. Management, it varies depending on the process that's causing it, from my understanding. But certain medications that we could use would be like steroids, cytotoxic, immunosuppressive agents to help suppress or excess immunity, or ACE inhibitors to decrease the protein loss in the urine. Cholesterol lowering drugs, which will help with the lipids. Heparin, which reduces the vascular defects and improve kidney function. Diuretics, reduces edema and hypertension. And then my main understanding was like, we want to maintain plasma volume, because if it depletes, we'll have more kidney problems, like the
Right.
so we're maintaining and assessing patient hydration status. And then again, acute kidney injury can be avoided if blood flow is maintained in the kidneys. So
Very nice.
that's pretty much it.
Nice job. I like the color because that's your way of just kind of, yeah, I like that. Good job. Does that make sense? Anyone else want to share? Nice job. Thank you, Marco.
Thank you.
Another thing that I found was with the glomerular nephritis, that one like is more associated with complications dealing with the heart and lungs, like pulmonary edema and heart failure, and puts the patient more at risk for sepsis. Whereas the nephrotic syndrome is more associated with like it does have pleural effusion, but also more complications with like the blood coagulation and the thrombus formation, and they're at risk, like not so much for sepsis, but infection in general.
Good. Anyone else want to share? Whitney, Vanessa, Shannon has done, Samantha, Kenya.
So I'm not done with mine, but can I have you take a look at it? Because I set it up maybe a little bit differently than Marco.
Sure. Yeah, share it. Yeah.
Okay. Let me see how I can do that. Share screen. Please don't look at how many tabs I have open. I know somebody.
You wouldn't believe how many I
have. Okay, here we go. Share. You guys see that?
Uh-huh.
Okay, cool. So I kind of went more along the lines of like how the ATI book had these set up and their differences. So
Okay.
like risk factors and findings.
Okay.
Labs and diagnosis procedures, and then how we would care for each.
Go up a little more. Let me just double check on, so nephritis, so findings, that has your swelling around the eyes. Hugo said it looks horrible.
Well, Hugo can often
swelling around the eyes, mild to severe hypertension. So I think that looks pretty good. How about I think that's okay, honestly.
Okay. So like for examples, when I get this, like how I would care for each differently, will that count as my examples kind of?
Yeah, that's how I would see that.
Okay,
what are we doing then for this patient when we're talking collaborative care?
Perfect.
We talked about kind of those tasks that we as nurses are going to do, and think about why you're doing them.
Mm-hmm.
But also what other for collaborative care, what medications, so that would be from the doctor,
Mm-hmm.
pharmacist, and then nutrition, right? What
Mm-hmm.
kind of diet changes?
Mm-hmm.
Yeah.
Okay, cool. Thank you.
Okay. Anyone else?
I'm happy to share mine if I can remember. I just push share screen on mine.
Yeah, yeah,
And then once I push share screen, I just go into my document.
yeah, you should be able to. Just,
Okay, let's see.
I act so confident, huh? We'll see.
Let's see. Can you guys see my screen?
We're seeing, yeah, we can see your screen. There you go.
Can you see
Yeah, yep, we can.
I just put mine in, like, I put kind of the nursing care along, like, with everything else, and just kind of made mine a little more simple. It sounds like everyone else did a little bit more than I did, so I don't know. But things that I would do similar would be, you know, like provide bed rest and diuretics and sodium restriction. So if that helps. And then other things that I included in here were like, you know, the acute nephrotic syndrome, you know, they might use anticoagulants or vasodilators. And then, you know, like the nephrotic syndrome might be, you know, the patient is more at risk for the coagulation or clotting issues. So in case that helps.
I actually really like that, seeing the similarities as well.
Yeah, I mean, it really is gonna, Shannon, it's got, I mean, I can't see anything that's really missing as far as, let's see. You might want to think about, do you have anything about like the collaborative care as far as diet for each one, or?
No, I just put the sodium restriction, like under the similarities. I just put
Gotcha.
that the patient will require bed rest, diuretics, and sodium restriction, but I didn't give like specifics with that. So I just put,
So,
you know, kind
yeah, I mean, the more specific you make it, the more of a you know, kind of study sheet it is for you.
Right.
But that's got the basics, what's in there. Yeah.
So do I need to add more to it? Do you think I already submitted? I can resubmit it later if you need.
Offhand, I'm not seeing anything. If this is, I think that's fine. Yeah. I mean, you can see people did it differently. Whitney, are you there?
I'm here.
Do you want to share yours?
Sure, you can see mine.
Do you want me to share it, or?
Oh, you can share it, sure.
Okay, just a sec. I'm just kind of pulling them up. It doesn't, let me see if it'll download for me.
I just kind of used the book Iggy and went down it and compared them.
I don't know if it's gonna give you the full benefit of this, but we'll see. Let's see. Okay, so Armel says she's doing hers the same. Let's see here. I just pulled people's up. It's not, so see, it's not really coming all the way through, but this is how Whitney set hers up. Do you want to, it looks like you have same as what, it looks a little bit like Marco's. You know, you did more of a, I think I would call it more like a latte kind of thing, they call it. So
yeah, I mean, I just read through Iggy and just pretty much marked down how it made sense to me and how they compare.
Understanding the pathophysiology is going to help you. What the different symptoms, the management, because this is the, you know, whether like, and Shannon, the way you had put yours, just, you know, doing the similarities and the differences is good. So yeah, but this is how people did them, guys. So this is what I'm saying. There's lots of different ways to do this. Okay. Where did my, sorry, I can't see that. Let me stop sharing so I can see your comments.
Amanda wants to know if we could do a Venn diagram.
Yeah. I need Whitney to explain how she comprehends that Iggy book. Haha. I honestly, guys, I like the color and the Venn diagrams and the concept maps, and it, for me, my learning, that's how it makes sense to me. I have to use bullet points. I have to write, if I look at a paragraph from like Iggy, I have to break it down that way. And just to make you guys feel better, I told you the story of my husband. I was trying to explain to him about cortisol. Did I tell you guys that? And how it's the adrenals and the stress as a hormone and stuff like that.
Yeah, and he asked you how the heck your students understood it.
Yeah, I gave him the Iggy book to read, and he's like, this morning he said to me, I still need to go back to that and read more about that, but he was like, do the students have a dictionary next to him during this? My husband's not a dumb guy, so give yourself credit.
Oh no, I carry a dictionary, or I look it up with Google. So we do, or I do. So
okay, yeah, good, because I still do too, because some of this is like, what? So okay, sorry I kept you a little over again, huh? Any questions? We're good. I hope you guys have a great, whoever celebrates Easter, happy Easter, happy spring, happy Passover. So, okay.
Amen, sister.
Yeah.
Mrs. Thorpe, I have a quick question.
Yes.
So in the Iggy book, when I was reading it, it said that the GFR for nephrotic syndrome is decreased, but in ATI it said the GFR is normal or high for nephrotic syndrome, but does that differentiate between adult and child?
You know what, Francesca? I don't know. So it says the ATI says what?
It says normal or high GFR for nephrotic syndrome.
Gosh, I don't know. Does anyone know that offhand? But in Iggy, it says something different.
Yeah, it says decreased.
One thing to take a look. I'm not familiar with what it is specifically you're talking about, Francesca. But when you're talking about GFR, increased glomerular flow means decreased GFR. So they are kind of like flip-flopped. So you may want to look exactly. If one says GFR and the other says GFR and they have two different directions, then obviously, yeah, that must be a mistake somewhere. But when looking at that, yeah, that if there's increased flow through the glomerulus, that will decrease the GFR. So it's kind of like opposite. It's weird.
So I just did a quick, didn't go into the book, but it says reduced GFR not due to hypovolemia has been reported in patients in the proteinuric phase of the MCNS syndrome, which is more in kids, right? So it has been, reduced glomerular filtrate. So maybe I would have to look at that further, but say that again, Hugo. You said an increase in GFR.
So it has to do with the amount of flow. Sorry, I just took a bite of food right after I said that. It has to do with the amount of flow of blood through the glomerulus. Increased flow of blood will decrease the GFR and vice versa. And so you'd have to really kind of take a look at the wording of what it is they're saying. Now, again, if one says GFR and the other says GFR, well, then it something's going on, something's different, but it could be in relation to that.
Yeah, I just checked and they both say glomerular filtration rate. So yeah.
Okay. Yeah, then don't pay attention to what I'm saying.
But thank you for that help.
Francesca, can you do me a favor? Send me Do like a copy and paste on a document and send it to me in the email. Or put it, yeah, I think just send it to me in an email and I'll double check that, okay?
Okay, from the textbook?
Yeah, if you
Okay.
can.
Yeah, I
Can you?
Yes,
Okay. I mean, don't make it too hard for you, so,
thank you.
all right. All right, guys, have a great weekend. I'll obviously be around and I did open up that so you can upload your stuff for the quiz now. If you already have the quiz, just get it over with, right? I just opened up that assignment.
Thank you.
Thank you.
Okay.
Again.
Okay, you too. Bye, guys.
Thank you, bye.
Bye.
Bye. Have a good weekend.
Bye, you too.
Thanks.
Ms. Thorpe, I had a quick question. I just didn't want to keep everyone.
Yeah.
So there was a question, well, when we were going through the questions during the slides, and it was talking about the proteinuria being 2+. In the slides prior, it said proteinuria 3 to 4+, and I just wanted to make sure there was no discrepancies between the information.
So I think my thought on that was that they were just trying to tell you 2+ is not normal. 2+ protein is not normal. So really, unless you have trace to 1+, that might be, okay, you can give or take on that one. But when you start getting up into the 2+ and above, that's considered on the edge of abnormal. So it's not really the question was wrong. It's just supposed to steer you in that direction, right?
Okay, just steer in the direction of abnormal
Yeah, it's
proteinuria.
one of those things that's gonna make you second guess yourself.
Okay, perfect. I just
Basically.
didn't want to have like a test question on it, and then I have like I'm like, oh, well, it's 2+. Technically, it said 3 to 4, and then
Yeah, and I think it was, I can pull it up real quick. It was at the end here.
Ms. Thorpe, I have a quick question for you.
Yep.
Not a question, but kind of like ask for a favor. Would you mind copying that? I know most of the lectures or you're discussing today was from the McKinney book. Would it be possible to have? I don't have the book, but would it be possible for you to maybe make copies of the specific chapters that you were going on about, so we can go ahead and read it over the weekend?
Yeah, it's basically that one came from 42 in the McKinney, I believe. Let me see. I'll double check here. But on that, just real quick on the question, urine dipstick, edema, the ankles, hyperlip, the one that all of them were there, Isaac, except for the polyuria.
okay.
Yeah. Let me see here. Let me just go back over here and look at I know, I wish. So do you have you don't have access to this though, huh? Let's see. No, it's not. No, it's chapter 44.
Miss Thorpe, what is the name of that book?
McKinney. I'll show you the outside of it. Let's see.
Yeah, please.
Yeah, it's called
Maternal right here.
Child something, right? Child.
It's called
I think
Maternal Child Nursing.
Your camera's not on, so I can't see it.
Oops. So. It's right here. Let's see. Maternal Child Nursing. That's actually the study guide. Let's see. Right here. But this is, I know, I'm not really sure why, well, so that's what the cover looks like. There are copies of this book, I believe, in the Are you there still?
Yeah, I'm here. Mhm, I'm
Okay.
listening.
There are copies of this up on the floor at the college. There's not a way for you, can you guys add this to your vital source? I mean, is there a way you can do that? I'm not really sure.
Only if we pay for it.
Yeah, I think we have to purchase it in order for it to have access to it.
It's like $125.
And I don't know, is there a way that I copy and paste it somewhere? I mean, I don't know, honestly. But... I mean, it is a nice book for the child stuff, but I guess they just didn't want to make you guys buy a book for, you know, just parts of stuff.
So you don't have the hard copy, you only have the ebook?
I have a hard copy. Do you need I mean, how do I get you a hard copy?
No, probably nearly impossible. I mean, it'll be expensive. But
No, I'm saying if there's not, I think there are some at the school. I mean, I could bring in my hard copies, you know, and you guys could share them. Do you want to do that?
yeah, I don't really know how to go about this, but yeah, I was looking online and see how to do this, but I figure probably will ask you maybe just screenshot those chapters and probably post it up for everybody to read it, but I don't really know how to solve it.
I could ask, you know, my daughter's coming today. So maybe she can help me do that.
But we're not responsible for the readings in the book, right? Just your slides and the words that you said today.
Well, yeah. And what I could do is open up, I think the instructor copy has a little more to it. I could just open that up on your module, so you have that one. Okay.
Okay, thank you.
Okay. Other than that, I'll see if she can help me, because I know in my growth and development class, they have the book, some of the chapters of the book copy, you know, put on there. I don't know if it's because the book is outdated or whatever, but so I'll go ahead and open up the instructor one, okay?
Okay, perfect.
It
Do you know
has-
if the fourth semester uses last year?
Yeah.
Is that the book they were using last year? Okay.
That's a great idea. Yes, they did. And I'm sure they're not using it now.
Yeah, I'll probably reach out to my mentor and see if they're not using it. Maybe you can hand it over.
Yeah, that's a great idea.
Okay. Thank you, Ms. Thorpe. Have a good weekend.
Okay, you too. All right, guys. You good, Hugo?
Yes, all good. It looks like I found a copy of the maternal child health study guide.
Oh.
It's not the actual book, but I'm looking at it right now and it looks like it has some cool exercises that people might be able to do in order to kind of help to like study better. And so like there is a helpful hint page where it says to review the anatomy and physiology of the renal system. There's like a matching key terms page where it has like some, you know, some information. So I'll see if I can extract those pages from chapter 44 and send those over to you so you can take a look at them.
Awesome. Okay.
And it might be something kind of cool just to put up for people to have just like as an extra study resource or something.
That's a good idea. Because it seems like the way these objectives are for this week, they kind of do, yes, it is some on adult, but I think like this part of the GU part, I think it's going to focus more on the kids.
Yeah,
on the
yeah,
children.
that's what it's looking like, yeah.
So, all right, sounds good.
I'll email it over to you.
Okay.
All right.
Thanks, Hugo. Okay. Bye.